Thanks for that introduction. It was very kind. And thanks for all being here. I thought a policy session would surely clear the room. And I am going to talk about comprehensive care, and I'm sure my presentation will come up any time now. But I do work at the Australian Commission for Safety and Quality in Healthcare, and it has a diverse range of roles and responsibilities in relation to safety and quality in Australia. It came about in 2007, and it's a COAG-funded organisation. Oh, there you go, I'm clearing the room. Just like that. But the thing that you would all be familiar with is accreditation and the national standards. And I think mine will come up now. Accreditation and the national standards, and within that role I work in the Partnering with Consumers team, and we look after standard what is going to be from next year standard 2, 5 and 8, which is partnering with consumers, comprehensive care and recognition and response to acute deterioration. And you might know that in this second edition of the standards there's been some changes, and comprehensive care is the new one. So here's our standard slide about the Commission. It has we do our work plan 3 years in advance, so I already know what I'm going to be doing for about 2022, and I'm sure most of it will be around the comprehensive care standard, although I know in Australian hospitals there are really good processes in place to ensure patients get good comprehensive care. And it's something to also note is, even though I'm going to talk about things that don't go so well in hospitals, that I think it's something like 96% of hospitals pass accreditation on the first go, and it's a very small amount that have to go through, some of those recommendations and get re-accredited. But yes, so the second edition of the standards will come into effect from 1 January 2019. And if you're familiar with the old set, there were 10 standards, now there's 8, and we're going to be talking about comprehensive care, which is standard 5. I prefer not to refer to them in numbers because it's better to think about what the context of the standard is. And I think this one's important because I really think that if we had comprehensive care right, then we probably wouldn't need recognising and responding to acute deterioration. That's an opinion. I'm sure you guys will have something to say about that. There are a whole bunch of resources that have already been developed for the standards. So if you're coming up to accreditation in the first half of next year, don't worry, don't panic. There's plenty of resources for you. There's a guide for hospitals, there are guides for smaller facilities, there are certainly the National Model Clinical Governance Framework, which is very important, and there's an accreditation workbook, and in all of those books there's heaps and heaps of stuff that will help with meeting the criteria in the various standards. Comprehensive care is a monster. It has 36 actions and 4 criteria, and we're going to go through those today. All right. So, what is this one about? Well, you would all know, and I was really glad to hear Ronaldo talk about common sense approach. I think this is a common sense standard, that there are a whole lot of cross-cutting issues that lead to adverse events in hospitals. And I think that, if we make sure we get the foundation of care right and our comprehensive care plans right, and then we act on those, then, we can reduce some of those things that cut across, particularly in relation to communication, so communicating for safety and the governance structures. If we get all of that right, we can get this right. So this standard focuses on care that also balances up patients' preferences, their values, and it sort of, as long as care is clinically appropriate but also takes into consideration those family patient carers and all of those things, then we can, really work towards making sure that care is provided in a way that meets everybody's needs, and I think that's really important. Now, the other thing to think about in comprehensive care is that it incorporates the 2 standards from the previous edition, so the first edition of the standards, which is falls and pressure injuries, in the 4th criteria, which is minimising harm. So the intent of the standard is always what's really important, and I just want to take a poll. How many of you have read the second edition of the standards? Hands up. Oh, there's a few of you. That's really good. And I'd say that the comprehensive care standard is a short read. It's a few pages, but there are 36 actions. And this standard is all about aiming to ensure that consumers receive care that's aligned with their expressed preferences and healthcare needs, considers the the impact of their health issues on their life and well-being, and it's clinically appropriate for their circumstances and minimises their harm. Now, I guess one of the things I know from looking after patients is we try to think about all of those things when we're giving care, but sometimes care is provided in a somewhat clinician-centric model, and I think this is the standard that will balance that up and make sure that we really remember to focus on, because sometimes patients don't exactly want what you're providing, so we need to just make sure that that's all balanced. Okay, so the 4 criterion are all about systems and supporting clinicians to deliver comprehensive care, developing the care plan, delivering the care plan, and minimising harm. And I really think that the minimising harm criteria actually belongs up at the front of the standard in those first few actions, because the first few actions are really all, and you'll find this throughout all the standards, in every standard, those first few actions are all about making sure you've got standard 1 and standard 2 in place, and that is the governance and the partnering with consumers aspects of the standards. If you've got those in place, everything should flow out of that. So, clinical governance and quality improvement is making sure that we link back to all of those standards. We encourage thinking about all the standards together. So how many of you, when you do accreditation, have 8 or 10 different folders that look at the standards separately? How many of you do that? There's a few of you putting your hands up. I know in every hospital I worked at, you'd have 8 or 10 separate folders that looked at every standard separately. And I think really this is where we need to really think about bringing those standards back together and looking at them together. And this is the first criteria in this standard is all about making sure you think about all the standards together in care. We take a quality improvement approach with engaging with consumers, and we do all of these things as par and parcel of care. So I was encouraged again by the sessions I heard this morning, and encouraged by the previous speaker to see those quality improvement approaches being implemented at the bedside. And obviously you can't do it in isolation. It all has to be about making sure that the governance and culture of the organisation supports the delivery of comprehensive care, and that there are systems and processes for clinicians to do the work they need to do. So I'm all for making sure that the resources are available for everybody to do what they need to do. The second criteria is about developing the comprehensive care plan, and we're about to undertake a few more actions at the national level in relation to this. But it's about making sure that there's appropriate screening and assessment, identifying the risks of harm, making sure that Aboriginal and Torres Strait Islanders are acknowledged and recognised so that you can work on any additional risks, developing a plan that includes the patient and all their support people, family, carers, others, and documenting findings, alerts in the plan. The third criteria is actually the delivery, so the day-to-day job of giving good care, and also this now has a whole range of actions around delivery of care at the end of life. So action 5.15 to 5.20 are all about end-of-life care. The fourth criteria is the minimising risk of harm, and I'm going to give you a bit of data because I really can't go through a session without giving you a little bit of data about the minimising harm. Some of you may know that one of the other things the Commission does is has produced a hacks list in consultation with clinicians and looking at all of the administrative data to see what goes on. So if you look at some of the hacks that are on the list of 16 hacks that relate to comprehensive care, pressure injury, falls, they're all things that come up, but the big kicker here is delirium, and certainly I know in ICU delirium is something that's being focused on, and there's a whole session related to that, so that's really good. But it's a high rate, and it's something that we need to deal with, and I was also encouraged to hear about the Victorian standards around nutrition in ICU, because malnutrition is also an issue. And to make it even more specific for ICU, a couple of years ago I looked at some data for the Clinical Excellence Commission around the incidents in intensive care units. And this is just the overall snapshot of what was going on in those years. Most things were pressure ulcers, and that's because it's in New South Wales it's mandatory to report pressure ulcers, so that's always going to be one of the highest things. Clinical management, medication and IV fluids come up. There's all of the medications that come up in those incidents come under high-risk medications, and plus the addition of vasopressors. Documentation comes up, medical devices come up, falls come up, but in terms of resulting in serious harm or death, there was only one in that whole lot. And the other thing that came up quite a lot was nutrition, which I was quite surprised about given how long there's been early nutrition guidelines in intensive care. So, these things do happen and they continue to happen in intensive care as well, and it's good to have a look at your own data and make sure you know what's going on in your unit so that you can make improvements when necessary. So what has this led us to? So in terms of comprehensive care, what we're doing at the moment is developing a whole lot of companion documents for the standard, because we know that given that this is a completely new standard, there will be obviously some concern out there to make sure, because obviously facilities will want to know how they can meet the standard. And so one of the things we did a few years ago was interview people from around the country and talk about, well, what does comprehensive care mean? And when I had a look in the last 18 months at all of those interviews, there were many, many, many hours of transcripts. It basically came down to some very simple things. At the base of it, you need the right culture in your organisation, a culture that supports comprehensive care and patient-centred care, and you need the clinical governance that supports that. Within that, you need the systems and processes that allow you as clinicians to do your work, and then that allows you to focus on the patient experience and improve it and make being in hospital something that's not to be dreaded by patients. Because being in hospital is just a touch point for people who come in and have to have their care taken. And we know that if you have something like an intensive care stay, that your quality of life beyond leaving the hospital is reduced compared to people in your similar age group for many years after. So that's one thing. The second companion document we're looking at are the essential elements of comprehensive care. So we decided we would break it down and work out what is required to achieve comprehensive care. And this companion paper will be published in the next few weeks. We're just waiting for the final design touches. But they seem pretty obvious and pretty common sense. And they are common sense. It's all about making sure that the clinical assessment is done, that diagnosis is correct, because we know diagnostic error and cognitive bias can play into care in hospitals, that we identify what the goals of care are, both from the clinician side and the patient side, because sometimes they're a little bit different, and we need to make sure that we marry those things up, and we make sure that, say, conversations that happen between clinicians and patients are communicated to everybody in the team so we're all working towards the same goals, because that's super important. We need to also do our risk screening and assessment. I did try very hard to get rid of screening, but it didn't work. We need to develop a single comprehensive care plan, because the most common question I get is, well, we've got all of these risks listed in the standard. How is it that we develop comprehensive care plans for all of them? We have one comprehensive care plan with all of the vital information there for everybody to see, so everybody's acting on the same information and we all know what the risks are. We deliver comprehensive care, that's the bread and butter. I'm not going to tell you how to do that, you all know how to deliver care. And we have to also review and evaluate our comprehensive care and delivery to make sure that we're actually meeting the goals that were set and we're meeting all of the targets that we need to meet. So we've put this all together in a diagram, and like those 6 things, they're not linear. I know they're not linear. We've presented them in a linear fashion where it goes 1, 2, 3, 4, 5, 6. Really nice, isn't it? And I know that that's not the way hospitals work and flow. So we've sort of put it together into a diagram to try and present it in a more dynamic way. But we know you need to pick up all the information and put it together, and then you provide care in a dynamic model, and that's exactly how it should happen, and that's what we want for patients, but all of those elements need to be part of it. If you need further resources, there are plenty available on the Commission website. I've put this presentation will be available, so you can just click on those links when you access this presentation. So there are plenty of guides. All the companion documents will be on our new pages, and we'll be continuing to develop further resources as required. At the moment, in the next few weeks, we have a comprehensive care nursing and midwifery advisory group convening to look at nursing-specific resources, but we will also be just developing general resources, because it's not just about nurses, it's about everybody working together, because teamwork and collaboration are really big ticket items in the comprehensive care standard, and everybody has to work together to make sure we give good patient care. I have to give a shout out to the Caring for Cognitive Impairment campaign. Join the campaign if your hospital hasn't. Get them on the list. This is all about delirium and dementia. It puts all of those, there are a whole heap of resources in relation to that campaign. Unfortunately, Anne couldn't come down and speak today, but in the delirium session, I know Gideon will be giving a plug to all of the delirium clinical care standard and to the Caring for Cognitive Impairment campaign. You can join it as an individual or as a hospital, and there are plenty of participants and lots of resources there, and that will help with delirium. If you need any advice or any support with the standards, you can contact the Commission through any of our various contacts, and I can tell you now that we have time. We have time and pressure put on us to answer any queries in a day of them coming in. So feel free to send any of your queries through to the advice line. And I might wrap up there. I don't know if there's time for questions.